Welcome, everyone, and thank you for joining us today. Before we begin today's webinar, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. My name is Tracie Napoli, Director of Fund Development and MARCOM at Osteoporosis Canada, and I will be your webinar moderator for today. This presentation will provide general information about lupus, bone health, and osteoporosis. It is not intended as individualized health advice. If you have questions about lupus, bone health, or osteoporosis, consult a physician. Now, during the webinar, if you do have a question, you can click the Q&A icon at the bottom of your screen and enter it there. We will do the best to answer as many questions as we can during the webinar within the time available. Osteoporosis Canada is the only national organization serving people affected by osteoporosis. The organization works to educate, empower, and support individuals and communities on bone health and in the risk reduction and treatment of osteoporosis. We provide medically accurate information to patients, healthcare providers, and the public. Services include programs and support groups, educational webinars, podcasts, digital tools, and resources, all available at osteoporosis.ca and also community resources. Today's webinar is Lupus and Bone Health. Lupus is a chronic disease with a variety of symptoms caused by inflammation in one or more parts of the body. Having a condition like lupus can be a risk factor associated with osteoporosis and related fractures. I am pleased to introduce our presenters, Dr. Carrie Ye and Dr. Stephanie Keeling. Dr. Ye is a rheumatologist at the University of Alberta Hospital, K. Edmonton Clinic. She specialized in osteoporosis and rheumatic toxicities of immunotherapy for cancer. She is the medical director of the Multidisciplinary Bone Health Clinic and the program director of the Northern Alberta Osteoporosis Program. Dr. Keeling is a professor of medicine and rheumatologist at the University of Alberta. She participates in clinical research in inflammatory arthritis and systemic lupus erythematosus and established the Lupus Clinic of Northern Alberta. She works with the Canadian Rheumatology Association and Canadian Network of Improved Outcomes in SLE in guidelines for lupus diagnosis and management. Please welcome Dr. Ye and Dr. Keeling.
So good morning, good afternoon. I guess I will start. I think we're going to share our screen. So thanks so much, everybody. I'm Stephanie Keeling, and on behalf of Dr. Carrie Ye and myself, I think we're both really thrilled to be here. So we're going to talk about lupus and bone health. And as mentioned, you know, if you have questions that are more pertaining to particular cases to do with yourself or somebody you know, those might be best served from asking your physician or a rheumatologist should you have one. So we'll move on to disclosures. So these are my disclosures and some of the work I do with various pharmaceutical companies, as well as also the Lupus Clinical Investigators Network is a North American group of rheumatologists who do a lot of lupus research, which is actually quite amazing. We'll go on to the next slide. And so these are Dr. Carrie Ye's no financial disclosures and her work with Osteoporosis Canada. So we'll go to the next slide. So our goal today is to hope that you understand what lupus is and how it can affect bone health, and talk about some treatment strategies that can improve bone health for people with lupus. So on the next slide, you can see that lupus is the disease of 1,000 faces. So you may recognize, and we can click on the next slide link as well. that you see a lot of famous people and people that you may know who suffer from lupus. It can affect many areas of the body. And it is an autoimmune disease where your body turns against itself. But in 2 people with lupus or 5 people in a room with lupus, you can see very different manifestations. So you may not ever have the same thing as somebody else, but there are certain commonalities, which is why they're all grouped together as lupus. So we'll go on to the next slide, because people always say, who gets lupus? So typically it is women of childbearing age. And the most common age would be between teenage years to in the 40s. But men, children, even occasionally babies, teenagers, and the elderly can also be affected by lupus. And the age range can vary. And even though it is driven by the female gender, we know that the male gender also can be affected, and it can be quite serious. So we're going to go on to the next slide, because in Canada, I guess you may wonder, well, how common is lupus? So it is about 1 in 1,000 Canadians who can be affected, based on studies by some of our colleagues across Canada. So a couple of our colleagues, Dr. Bernatsky in Montreal and Dr. Barnaby in Calgary, have done work looking at different populations of how lupus affects people in Canada. And what you can see is that it's roughly, depends on where you look, but it can be like the incidence, meaning new cases, can be about 3 per 100,000 person years, or maybe, for example, prevalence. That means in total in a population, how many people you see with lupus, that it can affect 27.3 per 10,000 females. So what's important to note too is that there is a greater percentage of people with autoimmunity in our Indigenous populations, and they can have quite severe active lupus as well. So we'll go on to the next slide. People always want to know, what caused my lupus? What has happened? Is this hereditary? Is it something I did or didn't do? And so the answer is, it's multiple potential things, and there's not one answer to that question. So there are things that happen in your immune system that can increase your risk of getting lupus. We do know there's a lot of different genetic changes that might increase your risk of getting lupus. So the immune system is really complicated. We're not going to get into the details of that, but just recognizing that some of the different parts of the immune system may be slightly different because of underlying genetic changes. Then you add on to that other layers that might, in the person with the right genetic background, they may experience certain environmental factors. For example, ultraviolet light. Perhaps they've had several infections that might trigger some things. There's some environmental theories about silica dust, which is something that you might see in the dirt and pottery and so forth, and even sometimes medications. We see there's a lot more female to male ratio for having lupus. And so there's a lot of theories and work looking at the balance between different hormones. So between estrogen, progesterone, and something called the hypothalamic pituitary axis. So all of that to say, you can see that there's not just one thing that probably plays a role into what finally manifests as lupus, but all of it contributes to a change in the immune system. So we'll go on to the next slide. There's a couple more theories about lupus and what happens in the immune system. So in simple terms, we know that there's your natural immune system. So let's say you get sick and you cut yourself, and then your body tries to fight this so that you don't get infected. You have a natural thing called your innate immune system that fights for you right away. And so there's some theories that this innate immune system is not working properly. On top of that, your body doesn't seem to recognize itself. And so this is this whole idea of autoimmunity. And so it starts to look at parts of you and thinks that it's foreign, that it doesn't belong to you, and it tries to fight it. So that is an important piece. And then the other part is what I call garbage cleanup. So all of us, all the time, all the cells in our body are working to kind of clean up the mess and get rid of it and make sure that we're running at 100%. And so in somebody with lupus, the immune system is a little messed up, and it is not good at cleaning garbage. So when all of this happens, we'll go to the next slide, you can manifest different things. So again, lupus can do a lot of different things, but one person may not get all of these things that you might see. This is taken from somebody who wrote a review about lupus in one of our rheumatology journals. And so it gives you a sense of where lupus can cause problems. So I would say one of the most common things that happens is what we call musculoskeletal complaints. So it's kind of at the bottom, they're saying, so different types of arthritis or joint pains or problems in the tendons can occur. Skin or cutaneous manifestations is very common. So for example, up to 70% of people might have this. And there's different kinds of rashes that can occur. You can also get sores in the mouth and nose. But you can also have inflammation in other places. So the lining of the lungs, the lining of the heart. And one thing that can really be problematic is when you get inflammation in the kidney. And so roughly a third of patients with lupus may have kidney issues, which can be quite serious and drive how we treat you. Other things can happen. Your blood systems, like your red blood cells, your platelets, your white blood cells can be affected. And then sometimes it can affect the brain and cause inflammation or other problems as well. So we'll go on to the next slide. I will acknowledge that I did like that in 30, 60 seconds. And we know that each of those manifestations I could give you an hour talk on, but I promise I'm not going to do that today. So what we just want you to see, though, is the vast array of different parts of the body that can be affected by lupus. And some people may just have skin. Some may have joints and skin. Some may just have kidney, or some can have all of the above over their journey in this disease. So our goal is to treat it as quickly and as effectively as possible. We want to calm down the fire of the inflammation, the disease activity, and get you ideally into remission. We also want to do that fast as we can so we don't cause permanent damage to the different organ systems. And we know that there's a lot of comorbidities, so additional problems that either the disease or the treatments we use can cause. And I think a big one here is obviously bone health and osteoporosis. So one of the other things we have to do is avoid side effects of treatments. So on the next slide, you will just see in general, this is super, super simplified, but what we do to treat people with lupus. And all of this is to cool the disease down. So probably the most common drug we use is something called hydroxychloroquine, which is an anti-malarial drug. And so this drug helps to kind of rejig your immune system to cool down all those parts where maybe the immune system is attacking that it should not be. And then on top of that, the rheumatologist or sometimes kidney doctor or other specialists will decide what other things do you need? Do you need steroids to cool down the activity? And then do you need something more long-term? So something to calm down the areas of the body where the immune system is showing active lupus. So I've listed some drugs here. I'm not going to go through them, but just to show you that depending on how aggressive the disease is and how at risk one or more organs are, that's basically how we decide which immunosuppressant, which are listed there. So methotrexate, azathioprine, stronger stuff like mycophenolate. There are some newer drugs as well, like the limumab and anifrolumab. That's how we decide where we're going to go. So we'll go to the next slide. And another real important piece I've sort of alluded to is additional things that aren't necessarily medications, but they're more for comorbid problems. So we know people with lupus can have very sensitive skin. They either get rashes from sun exposure, or sometimes they just internally feel worse or more fatigue. So we do recommend sunblock, protection, potentially with clothing that actually helps reflect UVA and UVB ultraviolet light. Then we may put you on a blood pressure medication if you have something called Raynaud's. And then we know inflammation affects the heart. So we work on trying to control problems that we can fix, like your cholesterol levels, high blood pressure. If you smoke, it actually can make skin lupus worse and also can reduce your benefit of drugs. So we really encourage smoking cessation, and physical activity, if possible, is good. And then we do age and gender appropriate malignancy screening. So now we'll go on to the next slide, and it's all about bone, and that's what today's focus is. And so bone protection is really important, and it's really from the beginning of the lupus journey throughout. So we know that lupus can affect all age groups, even children. And therefore, our drugs, as you're going to hear a bit more, particularly steroids, can really promote bone loss. And this is in all the age groups. And so every time a rheumatologist ideally is seeing their patient in front of them, in the back of their mind, as part of their care, they are thinking about what they need to do with bone health, if anything. But as I said, every patient is quite customized and personalized. So what you may hear somebody is on for their bone health may not be what another patient requires. So there's certain principles that we do apply. So now we'll go on to the next slide. And so I want you to imagine, we're going to start with this, and then I'm going to invite Dr. Ye to take over and tell us how she would approach Sally's lupus journey. So this is a made-up patient, but it's really a constellation of a very common type of patient we might see with lupus. So imagine you have a 25-year-old female, and she's very healthy until she developed lupus after she got a number of symptoms over the summer. So she did start noticing hair loss and scarring in the areas where she lost hair on her scalp. She developed what you might hear of as the butterfly rash or the mask of the wolf. So a really red fixed rash on her face with some scale that was around for weeks and weeks. She had sores in her mouth, and she developed arthritis with a lot of joint pain, particularly in her hands. So we'll go on to the next slide. Obviously, I'm summarizing a longer story, but she ended up also having a lot of blood work done, which confirmed that she had lupus in her kidney. So she was also seen by a nephrologist, a kidney specialist, who had to perform a kidney biopsy. And under a microscope, they identified that she had a particular type of lupus in the kidney called class 4 or 5 glomerulonephritis. So that's actually on the bottom left, the little purpley, it's actually kind of a pretty picture, is part of the kidney biopsy picture, which shows inflammation there. So she had a lot of treatments, and this included high-dose steroids intravenously at first, and then oral steroids, which were required to calm this down. And the priority there was to cool all this inflammation in her kidney as fast as possible so she doesn't have damage to the kidney. On top of that, she was put on an immunosuppressant. So in her case, it happened to be mycophenolate mofetil and hydroxychloroquine, the antimalarial drug, was started. So we'll go on to the next slide. And I will turn it over to Dr. Ye to talk about where does the bone health fit in all of this?
Dr. Keeling. All right, I'm going to switch gears here and focus on osteoporosis, and then we'll get back to Sally's case. So definitions of osteoporosis come from the World Health Organization, and they've been endorsed by other organizations as well. It can be defined both clinically and by something called a DEXA scan, which measures your bone mineral density. The clinical definition is just having a fragility fracture, especially of the hip or the spine. So just breaking a bone with low trauma is enough to actually diagnose osteoporosis. Then we have the bone mineral density definition, which is a T-score, and that tells you the number of standard deviations or how different you are from the gold standard peak bone mineral density. So if you're less than negative 2.5 standard deviations in terms of your bone density at the spine, the hip, or the neck of the hip bone, in postmenopausal women or men over the age of 50, you can also be diagnosed with osteoporosis. So some facts about fractures. Each year in Canada, there are about 30,000 hip fractures and many more other types of osteoporotic fractures, like the ones that occur in the spine, the wrist, the shoulder, and the pelvis. 1 in 3 women and 1 in 3 men will suffer an osteoporotic fracture in their lifetime. 1 in 3 hip fracture patients will actually break another bone in a year. And over 1 in 2 will suffer another fracture within 5 years. So we always say fracture begets fracture. About 20% of those who develop a spine compression fracture will get another one within a year. And we have very effective medications that can reduce fracture risk by 30 to 70% within just 1 year of treatment. The other important thing about fractures is that although they don't seem to get as much attention as other diseases, they're actually much more common in Canadian women than heart attack, stroke, and breast cancer combined. So this is a pretty serious and common issue. Fractures aren't just breaking a bone and it hurting. It actually has really important consequences on quality of life and even survival. So the lifetime risk of a hip fracture in women over the age of 50 is about 12%. And we know that once you've had a hip fracture, or sorry, 40% of those have actually already had a fracture. So they already had a warning sign that perhaps a hip fracture was coming. In women with hip fracture, 40% need help walking after a hip fracture. So for example, needing a walker, or some even requiring wheelchairs. And about 18% end up entering long-term care after a hip fracture within a year. And probably the most gruesome factoid here is that 23% die within a year. So hip fractures actually really significantly impact someone's survival. So I hope I've convinced you that bone health and fractures is really important to consider. And it's especially important in patients who have lupus. So we know that osteopenia, or low bone mass, is really common among patients with lupus. And depending on the study, it can range between 1/4 to 3/4 of patients having low bone mass. Osteoporosis, so that's actually having low bone mass less than -2.5 standard deviations below normal, or already having a fragility fracture, is present in up to 69% of patients with lupus. And the reason there's such wide ranges is really dependent on the population that was studied in these studies, depending on age or gender, ethnicity, disease severity of their underlying lupus, their medication use, and other things. We also know that there are 3 times higher rate of fractures in patients with lupus compared to those without lupus. And that's especially seen with vertebral fractures, which are seen in 20 to 60% of patients with lupus. So why do patients with lupus get osteoporosis and break bones? Well, the top reason truly is steroid use. So I put that as the top 3 reasons, because steroids, we know, are really detrimental to your bone health, and steroids are a really important part of lupus treatment. The other big thing is that we often counsel patients to avoid sun, because sun exposure can trigger lupus activity, but that can also result in vitamin D deficiency. Some of the medications that are used to treat lupus beyond steroids can actually suppress ovulation and that estrogen cycle in women. And we know that that estrogen cycle is really important to maintaining healthy bones. Due to lots of factors, lupus patients might be less active, and we know that weight-bearing exercises are really important in stimulating and maintaining healthy bones. Lupus patients can also be at increased risk of falls due to muscle weakness from medications, or inflammation in their muscles or joints, or just general deconditioning from being unwell. They can also have peripheral nerve involvement, so they might not be able to sense the ground or have troubles with balance. And lupus patients can also have seizures, and seizures can certainly result in falls and fractures. Further, just inflammation in the body from all sorts of diseases, including lupus, can directly impact your bones and cause bone loss. And then finally, when lupus affects the kidneys and the kidneys aren't functioning well, that can also affect your bones, because there's actually a very close relationship between how you handle calcium in your body, and that's regulated partly by your kidneys. Okay, I have one sort of technical slide in here about steroid-induced osteoporosis. And this is just to show you that fracture risk increases in those on 2.5 milligrams or more of steroids a day. This is just prednisone. 2.5 milligrams or more a day results in doubling your risk of fractures within 3 to 6 months. So very quickly, your risk of breaking a bone goes up after starting steroids. Okay. So I think the most important part of this talk is discussing how you would prevent bone loss and fractures. So there's some general recommendations that are important for everybody, like smoking cessation. Smoking, we know, can increase inflammation in the body, and also probably has some direct effects on your bones. Limiting alcohol intake is important. Maintaining normal body weight is important for bone health. Being overweight or underweight can harm your bones. Weight-bearing exercises can stimulate bone turnover and maintain strong bones. And then making sure you get enough calcium and vitamin D, which we'll get into a little bit more later. For patients with lupus, there are some other recommendations that we need to make sure that we touch on. So first thing is minimize steroid use. So steroids are really important in the treatment journey for patients with lupus. So we're not saying don't use steroids because it's certainly necessary in a lot of patients, but just making sure that the dose that you're on is the minimum amount to keep your disease under control. We also want to make sure that the lupus is well treated. Decreasing your overall inflammation and keeping your kidneys healthy and your joints healthy will also improve your bone health. We want to make sure that lupus patients get earlier and regular fracture risk assessments, probably earlier than the general population who don't have lupus. And we want to make sure that osteoporosis prevention treatment is started in a timely manner if it's necessary. For example, if you're on high long-term steroids, sometimes we'll actually put you on osteoporosis medications to prevent bone loss. And then if you've developed osteoporosis, we want to make sure that that's treated appropriately. Okay, so I touched on early fracture risk assessment, and the most common tool used in the world to assess fracture risk is something called the FRAX tool. We have one developed specifically for Canada, and I'm showing you this just to show you some of the important characteristics that contribute to your risk of breaking a bone. So your age, your sex, weight and height, previous fractures, having a mom or dad who broke their hip, smoking, steroid use, having rheumatoid arthritis, other causes of osteoporosis, Crohn's disease or celiac disease, excessive alcohol intake, and then bone density. So your healthcare provider might use this tool, enter in this information about you, and click calculate. And what that will give them is a sense of your 10-year risk of breaking a bone and your 10-year risk specifically of breaking your hip. Okay. In terms of getting adequate calcium and vitamin D, Osteoporosis Canada 2023 guidelines say that for people who meet the recommended dietary allowance for calcium, they don't recommend any supplemental calcium. So you don't have to take extra calcium tablets if you're able to get it from your diet. And in fact, we generally encourage getting it from your diet over taking supplements if you can. Health Canada's recommended dietary allowance for calcium is 1,000 milligrams. So getting at least 1,000 milligrams if you're under the age of 50, if you're a woman, or under the age of 70 if you're a man. And if you're above 50 years old as a woman or above 70 years old as a man, then we recommend at least 1,200 milligrams of calcium a day. So to give you an idea, each serving of dairy product is about 300 milligrams calcium. So if people can get about 3 servings of dairy a day, they'll usually meet the Health Canada requirements. Health Canada's recommendations on vitamin D is that in adults older than 50 years of age, they should take a vitamin D supplement of 400 international units a day, because most of us in Canada just don't get enough direct sunlight to make enough. However, people at risk of vitamin D deficiency, and in particular lupus patients, you should consider additional supplemental vitamin D. And then we get asked a lot about supplemental protein, vitamin K, or magnesium. In general, if you're eating a balanced diet and following the Canada's food guide, there's no need to supplement extra for your bone health. Okay. Another really important aspect of preventing fractures is physical activity. So first thing is you want to reduce your risk of falls. So balance and functional training at least twice a week is important. And also just being wary of your environmental risks. So for example, we see a lot more hip fractures when it's icy out. So being careful to use, crampons or other things when you're out walking on ice. Rugs are a fall risk in the house, and just being careful about your surroundings is important. Resistance training, and Osteoporosis Canada calls this progressive resistance training, is recommended at least twice a week. And that includes exercises targeting the abdominal and back extensor muscles so that you can protect your spine. And then vertebral fracture prevention is a really big part of what we counsel on in our clinic. Vertebral fractures can happen without falling. So even just activities like rapid, repetitive, sustained, weighted, or end of motion twisting or flexion of the spine can cause compression fractures in the spine when it's not very strong. And so these sorts of activities might need to be modified. For example, vacuuming results in a lot of twisting of the spine. So just learning to modify those activities so that you're keeping your spine safe is really important. A lot of this stuff is hard to do on your own. Unfortunately, there's a program called Bone Fit, which actually trains healthcare providers, including physiotherapists that are in the community, on how best to care for patients with osteoporosis so that they can recommend exercises and modified activities that will keep your bones safe. So you can actually go on this website or Google Bone Fit, and they have a map of your area of all the Bone Fit certified practitioners in your area. Okay, so moving on to pharmacological treatment. So we talked about some lifestyle modifications that you can do, but sometimes you need medications. So when do we talk about osteoporosis medications? Well, one is if you are considered moderate to high risk of having an osteoporotic fracture in the next 10 years. And that's, when we looked at that FRAX calculator, if that risk comes out at over 10%, you could consider osteoporosis treatment. The other one is if you're on long-term glucocorticoids. So generally, I say if you're taking at least 5 milligrams a day for 3 months or longer, you should at least consider talking to your doctor about being on a medication to prevent bone loss. Some of the options, which we won't go into detail today, include the bisphosphonates, which have been around for many, many decades now. The two most common oral ones are alendronate and risedronate. These are pills that generally are taken once a week. And then we have an IV form called IV zoledronic acid or zoledronate. We also have an injection medication that you inject every 6 months called denosumab. And then we have 2 bone building medications now called teriparatide and romosozumab in Canada. Abaloparatide is also just coming to Canada. And then there are hormone options like estrogen replacement. So for example, if you are going through menopause and you have some menopausal symptoms, estrogen might be prescribed for that, but that will also help to protect your bones. And then we also sometimes use selective estrogen receptive modulators such as raloxifene, but those aren't the main treatments for osteoporosis. So some questions to ask your doctor if you have lupus are the following. Do any of my medications increase my risk of osteoporosis or breaking a bone? You can ask your doctor, what is my fracture risk? And that might trigger them to do a fracture risk assessment. You can ask if you need to get a DEXA scan to measure your bone mineral density. And then you can ask, what are some things that we can do together to keep my bones healthy? So going back to Sally, her risk factors for developing bone loss or fractures include the fact that she's a female, that she's been prescribed pretty high dose steroids, that she has kidney disease, so that could impact her vitamin D activation and absorption of calcium. She has joint inflammation, and that inflammation can impact your bones, but also maybe will increase her risk of falls and her physical activity level. And also, she's going to try and avoid the sun so she doesn't get worsening rashes or worsening lupus activity, and that can result in vitamin D deficiency. So what I would recommend for Sally in this case would be that she should get at least 1,000 milligrams of calcium a day, preferably from her diet. She should get higher doses of vitamin D supplementation than the general recommendation. So I would recommend 1,000 to 2,000 international units a day. She should work with her rheumatologist to minimize her prednisone, and that's also why the mycophenolate was started, to try and get her off prednisone as early as possible. I would recommend exercise. I would recommend getting a baseline DEXA scan so that you can monitor her bone health over her treatment course. And then, depending on how long she needs to be on prednisone for and how her bone density is right now, you might consider actually putting her on osteoporosis medication to prevent further bone loss. All right, well, that wraps it up for us. I will stop sharing.
That was great. Thank you so much to Dr. Ye and Dr. Keeling. Very informative. We do have time for a couple of questions, and I'm actually going to grab the one that's in the chat, and this is for Dr. Keeling, and I hope I pronounced this correctly. Does hydroxychloroquine, yes, thank you, use promote bone loss? Can you speak to that?
Yeah, absolutely. And I think that's a good lead into the other immunosuppressants too. So with hydroxychloroquine, the anti-malarial drug that we most commonly put any aged patient with lupus on, the bottom line is no. So simply put, it does not promote bone loss at all, to my knowledge. I think Dr. Ye, you're nodding, so you would agree. And in fact, all of the immunosuppressants, so methotrexate, azathioprine, mycophenolate that we mentioned for Sally, even a drug called cyclophosphamide, which is a very potent, rare, less commonly used drug now, they are not real players in bone loss for increasing risk of osteoporosis. So as you've heard Dr. Ye say, it's really steroids or glucocorticoids, which is just another name for steroids, that really is one of the big drivers for our lupus patients. So rest assured, that's another reason why we encourage using these other immunosuppressants, depending on the situation, to try to minimize the total exposure someone in a lifetime with lupus gets to steroids. And I will say that I think over time, the lupus guidelines across the world, so for example, in Europe and more recently in America, and we're working on Canadian ones as well, there's work trying to actually say that the best dose of steroid is 0, none. So I know, Dr. Ye mentioned like risk if you're, stay 3 months or longer on 5 milligrams, more than 5 milligrams a day, that talking about bone health is important. And I think there's a paradigm shift in rheumatology to try even harder to minimize and get you down less than 5 and get you to 0. But the caveat here is, some patients with lupus rarely ever need steroids, and some may never get off them, and everybody's different. So we don't want to say steroids are evil, because they save the lives of many of our patients and their organs. But it's really the steroids, in addition to the other factors Dr. Ye mentioned, that I would say are the big players with the bone loss.
Wonderful. Thank you so much for that. I have a question for Dr. Ye. We have someone who is asking, if someone is trying to manage both conditions, lupus and osteoporosis, it can be very overwhelming. And in addition to any drug treatments recommended by their doctors, and you did touch on it in your presentation, but what can people do on their own to easily manage, if easily is a word we can use, both conditions?
Yeah, that's a great question. And we did touch on that. But things to do are just to make sure that, I would say, like living a healthy, balanced lifestyle, right? Like making sure you're getting adequate protein intake, making sure you're getting enough calcium and vitamin D, staying active, doing some strengthening exercises, and then making sure that you're working closely with your rheumatologist to keep your lupus under good control, because active lupus can certainly worsen your bone health. So I think those are the main things someone can do on their own. And the things to do on your own when maintaining good lupus control is, staying on your medications and staying out of the sun and avoiding triggers. I don't know if there's more you'd add to that, Dr. Keeling.
Well, I was going to add no vacuuming, because I think you've identified that as a significant risk for twisting and vertebral fractures. But no, I'm sort of kidding. No, I think it's fair. I think the hard part for some people with lupus is fatigue can be so disabling and so hard to push through that, even though, you know, Dr. Ye and I are sitting here talking about physical activity is so critical, weight-bearing activity that is important for the bone health. You know, I think if you're in a position where you just don't know if you can do it, and if you have access, like, for example, Bone Fit, as Dr. Ye mentioned, or if there's an ability to go see a physio to work on sort of a structured exercise program. Sometimes we use pool therapy in some places. I know the pool isn't like weight bearing, but even as a way to start moving to try to get that physical activity going, those are all for some people helpful ways to also, activity also may improve fatigue as well, because a lot of patients with lupus have other things that make it hard for them to move, pain, fibromyalgia, and other things too.
Thank you very much. So we have time for one more question, and this is for Dr. Keeling. And you just mentioned pain. So does lupus cause pain? Does it cause bone pain, joint pain?
So lupus can cause both. Typically, osteoporosis itself is painless until you break something, then that's painful. Lupus is something that can cause inflammation in actual joints themselves, and that will cause pain in those areas. Sometimes you can have other unusual problems where part of a bone dies. It's called avascular necrosis, and that can lead to sudden joint pain as well. Some people with lupus have pain outside of the bones, but it feels like it's in their bones and it's all over. And then we're not really focusing on that today, but that pain, some people call central pain syndrome or fibromyalgia. So it can feel like your deep ache is in your bones and in your tissues. And that is another type of pain, which is separate, but can also cloud the picture and be very confusing as what's the source of the pain.
That's wonderful. Well, thank you both so much. I'm just going to share my screen here. Thank you to everyone who joined us. This was a wonderful webinar, and you know what? We have more coming up in the next 2 weeks. On this Thursday, Dr. Andy Wong, he's going to be discussing origins of musculoskeletal pain. Next Wednesday, December 6th, we have a cooking demo. And Thursday, December 7th, we have a webinar on the importance of protein. And on Friday, December 8th, Dr. Rowena Rideout, she is going to be discussing what you need to know about the 2023 clinical practice guideline that was just released for osteoporosis. So you can register for all of these free webinars at osteoporosis.ca. Also, I'd just like to make mention, if you don't already know, today is Giving Tuesday. And when you do donate to Osteoporosis Canada, it allows us to do even more programming and provide more resources and webinars and podcasts and all the great stuff that we're able to do. We do have a match gift by the Colin Stevens Family Foundation. We're very grateful to them. They will match up to $10,000 if you donate by midnight tonight. You can do that at osteoporosis.ca/Giving Tuesday. And lastly, again, just make sure you subscribe. That way you get all of the information in your inbox. That way you know what's coming up, all the latest updates. We're on Instagram and Facebook. Dr. Carrie Ye, Dr. Stephanie Keeling, thank you both so much for a wonderful webinar. I hope you all have a lovely rest of your day, and we'll see you on our next educational webinar. Have a great one, everyone. Take care. Bye-bye.